Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning into my latest video. This is of a patient who was referred from their GP. They had been suffering from a chronic ear infection in the right ear, which is the ear that we just examined. And they had been using antibiotic ear spray for several weeks. However, their symptoms were still present, and in fact, they were worsening. They were complaining of really severe otalgia, which is earache, to the point where they weren't able to sleep at night. The pain was that unbearable that it was waking them up at night, and they had to take some painkillers. And their GP just advised them to visit myself. So what's in the ear? This is a combination of infected debris. I also think the patient has got a bit of Keratosis obturans. You'll see that a bit later. Now, there were a few fungal spores just at the entrance, so it's possible and plausible that the reason why this patient hasn't reacted to her antibiotic spray and treatment is because they actually have a fungal infection, and obviously using antibiotics on fungal infections is not going to bode very well. It's going to be ineffective. Typically for fungal infections in the UK at least, what's prescribed is Canesten ear drops. Sometimes some sort of acidic spray can help as well. The acidity can change the pH in the level in the ear and stop fungi from multiplying and breeding. But Canesten is normally recommended. Now, with fungal ear infections, they are well known to be difficult to treat because just as soon as you think you're on top of it and the infection's treated, it can come back with a vengeance. So Canesten drops, for example, I think it's minimum 2 weeks, and they do recommend to use it at least a week after your symptoms have cleared, as I think that's what the instruction says. And knowingly, because as I mentioned, fungal infections are quite difficult to treat. I've cleared the debris at the entrance. You would have noticed it was quite reflective. That's because of the infected debris. It was white in colour. So when we shine the endoscope light source into the ear, which illuminates the ear, we get a really bright reflection back. So I've cleared all the entrance. Now, this is the section which I feel is the Keratosis obturans, and we're very deep in the ear, and it was a bit uncomfortable for the patient. And I think in a moment I'm going to put some sodium bicarbonate drops, and sodium bicarbonate drops is very effective with dead keratin. So this is not wax, it's a bit of infected debris, but predominantly dead skin keratin. And because they've been using antibiotic spray for a while, the consistency of this skin has changed a bit. It's a bit mushy, but at its core, where I am now, it's still very embedded. So Keratosis obturans is a buildup of dead skin that collects into the ear, into a plug, into a ball, just like what we're witnessing here. In most people, the skin that lines the ear canal and the outer layer of the eardrum, as it dies and sheds, it moves sideways out of the ear naturally, and then you get another fresher layer of skin that's secreted underneath, and it's a continuous process. But for some people, the skin doesn't migrate, and instead it collects medially. So in this region, so we're medial at the moment, we're towards the eardrum, and it forms a plug of dead skin. And this plug of dead skin gets bigger and bigger as more and more dead layers of skin attach to it. And think about it almost like a rubber ball, and it gets wider and wider, it expands, it gets bigger, and it can start widening and compressing against the canal walls. It can be very, very painful for the patient. So I've just dosed the ear with some sodium bicarbonate drops. I find sodium bicarbonate drops much more effective with keratin skin compared to what I normally recommend and use is an olive oil spray for earwax. Now, the patient, because the procedure was a bit uncomfortable for them, I don't feel because of I was being aggressive, it's just the nature of the beast. When you've got Keratosis obturans, one of the landmarks is otalgia, pain, and this patient arrived with pain. So even before we proceeded with the treatment, they were in a lot of pain. In fact, she was holding the side of her head, the right side. So she asked whether we could just lay down on the couch. So with my ENT couch, you've got two options. Typically, you have the patient seated. The patients prefer that. But this patient asked whether she could lay down. She just felt it would be better. So you will see the angle of the ear is a bit different now. So where to the left, so at 9 o'clock is actually the top of the eardrum. So we've kind of twisted everything 90 degrees anti-clockwise. So to the right is actually the bottom of the eardrum. To the left, where we are now, is the top of the eardrum. To the top of the ear canal, that's the anterior part, the front part of the ear canal. And to the bottom, so at 6 o'clock, that's actually what would have been the posterior canal wall, so the back part. And the patient found it a lot more comfortable. And I'm just using a fine end suction probe. We're just going to detach this plug off the eardrum and off the canal walls. So I'm just being really, really gentle and cautious. We're going to just now peel it now. This looks like the roof of the ear canal, but it's not. It's actually the front part of the ear canal. It's just the way we've laid the patient down. And I've got a plug of keratin out there. And you just see the back part of the eardrum. So to the base, so at 6 o'clock, you can just see the eardrum appearing now. But that's actually the back part of the eardrum. If you imagine, as I said, the patient's laying down. And this dead skin is very mushy as well. It's adhered itself to the canal walls. And to the left, you can see where we are now. This is all freshly secreted dead skin. So this is a fresh layer of skin that has died, but instead of shedding out the ear, it's just remained in the ear. And to the core, so as the plug of skin, as we go towards the centre of the core, the colour gets darker and to almost a brown, and in the middle almost like a blackish appearance, and that's the oxidization process. So the longer the skin's been in the ear, it oxidizes and it changes colour. Now this procedure, I think it was performed at the beginning of December, and I still remember it really well because we just had to be really, really gentle. We're gentle anyway, that's not the reason, but I remember this patient was in such agony. And unfortunately, in the UK, being an audiologist, I'm not able to apply any local anaesthetic. So for that to be performed in the UK, the patient would actually have to be seen by ENT or a nurse, who sometimes a prescribing nurse or a prescribing pharmacist who are able to perform earwax removal, and they would be able to apply some local anaesthetic. Hopefully that can change in the future, but we shall see. So although I'm to the left of the ear, this is the top part of the eardrum. You probably saw the eardrum flex a bit there, so when we went close with the suction probe, the suction probe actually suctions the eardrum towards it somewhat, and you got a flexing of the eardrum. So we'll just be a bit gentle as well, be careful there. So although I'm to the right, this is the bottom of the ear canal. Now I'm to the top, and this is the right hand side of the ear canal. Most surgery, I'd say all ear surgery, the patient is always laid down in this manner. So I do watch a couple of ENT surgical channels on YouTube. One of them is from my colleague, Mr Darius Rajali of Ear and Balance. And when I'm watching it, I'm actually tilting my head to the side, so because I'm not used to viewing the ear in this manner. Typically for me, patients are sat up still, so when I'm watching the surgery, just to get everything in perspective, I give myself a bad neck and I tilt it. If I tilt my phone and you got the auto, even when I lock it, for some reason it doesn't, and the image still rotates sideways and anti-clockwise at 90 degrees. So we're actually in the anterior recess at the moment. So this would, if you normally watch my videos, this will be to the right hand side. But here it's appearing to the roof. And because we're using a fine end, because we're near the eardrum and the patient's obviously experiencing some pain, the fine end can get blocked quite easily, especially with this type of consistency of dead skin. As I said, it's very mushy. The suction probe can embed within it and get blocked very, very easily. You can see I've just loosened this plug now. So again, guys, this would be the front right-hand side of the ear canal. And we're just removing this on the anterior recess and just slowly bringing it down. I think it's partly blocked my tube. So just come out, unblock the tube. So because this has been lifted off the eardrum, the patient can hear significantly better already. And there we are, you can see the eardrum in the distance. Now, the patient has been using, as I said, antibiotics drops spray for a while, and they've also been using some earwax softening drops. And what can happen when you overdose your ear with any sort of fluid, you get a wrinkly appearance. It's a bit like when you go for a shower and you come out and the paddings of your fingertips get wrinkly. And the patient's eardrum looks very wrinkly to me. It's just because there's obviously been a lot of fluid in there, whether it be antibiotic drops or earwax softening drops. So the right ear finished. This is the same patient, but the left ear now. In terms of their right ear, we did write to the patient's GP requesting that they take an ear swab, just in case it is a fungal infection, and if so, they can then use the appropriate treatment. So the patient's left ear, there was a bit of a otitis externe at the entrance. There's a bit of a swelling. You'll see that a bit clearer as we remove the wax, and we get a different view in a moment. But just where the suction probe here is, you can see the ear canal goes upwards quite a lot. So the patient has got quite an inclined ear canal, but it was a bit puffy, a bit swollen, a bit of edema there. So you can see the eardrum already. Now, this patient's ear canal is very, very bendy, but I managed to navigate the bend. I'm using a fine end suction probe and just mopping up. It's a bit wet. They had been using some drops here. Now, even if we leave this, the patient can hear. But I think I managed to remove a lot of it. And we're going to peel some skin. The patient's eardrum's healthy. Just gently peel this up. Now, for this, the patient, we got the patient sat upright again. They were fine sitting upright for this part. And all this, in a minute, I'm going to remove all this. This is just a sticky layer of keratin that's just embedded itself at the entrance of the ear. You can just see how steep this ear canal is. We're just at the entrance here, and the ear canal goes all the way up. It's like a mountain, the side of a mountain there. You've got all this sticky dead skin. Whilst you're watching that, I'll just going to respond to a few comments and questions left at yesterday's video of the swollen ear. Some people wanted to know whether when the ear canal collapsed, when I was performing the procedure, whether the patient can feel it, and the answer is yes. They can actually themselves feel the canal collapse, and it does make a bit of a loud noise as well when it does. So can be a bit uncomfortable for the patient when the canal collapses, but because we came out immediately, they were fine. So I hope that answers that. Some other questions I think were relating to whether water is able to be used, and water, in that kind of scenario, water should be avoided. It's good to hear, because a lot of the comments in the past have related to modes of earwax removal in the US, and it seems to be like ear syringing and irrigation is quite common there still, and with those kind of conditions you wouldn't be able to do that. But it's good to know, because I've read through the comments, that in cases of ear infections, typically patients are being referred to ENT in America, or seeing them privately, or however the healthcare system works there, and they are having it suctioned, so that's good to know. So just using a Jobson horn now, just to kind of remove the sticky layer of skin. Put a bit of force, because on the cartilaginous portion we can put a bit of pressure here. It's not going to be uncomfortable for the patient. Some of the other questions received yesterday on the procedure, whilst again you're watching this, was whether the dry crusted skin at the entrance can be removed manually. In the case of the patient yesterday, it was so severe that you would be there all day just trying to remove that scaly skin, and it would be very uncomfortable, and it could cause to more infection because you're grazing that, and it opens up the epithelial layer. The outer protective layer of skin is then taken away, and the endothelium layer is exposed to bacteria, etc. So that is typically treated with ointments, cream, antibiotic sprays. The other question is whether when you've got an ear canal that's blocked right from the entrance all the way to the eardrum, whether it's visible to people examining the ear, or not examining the ear, but people beside that individual, if they're sat beside them looking in the ear. Sometimes yes, typically no though, because what I consider the entrance of the ear canal is, so when you look inside someone's ear, you see the aperture, the opening, and then it curls, if it's the right, to the left, if it's the left, it curls to the right, and it's just where that bend is. That's where I consider being the entrance of the ear. So some of it is concealed away. Someone else wanted to know whether earwax can smell, or actually does an infection smell. Now, even earwax can smell. If the earwax has been there for a while, earwax is acidic, so if it's been there for a while, yes, it can smell very acidic. Infections, of course, can smell. They have a really foul odour, kind of a rancid smell. If you've got being an audiologist for many years as well, when someone's got an ear infection and they're wearing a hearing aid, which they shouldn't really be doing, because you want sometimes it's unavoidable for them, of course, but you want to avoid wearing a hearing aid if someone's ear is infected, because you want to allow natural air in there. But as soon as they take the ear mold out, it really does smell. You spend a few minutes after the patient leaves just spraying air freshener before the next patient comes, because it can be quite an offensive smell. It's not personal to the patient, they can't help it, but yeah, ear infections can smell really bad. I suspect I've become a bit used to it now. I've become almost immune to it. And I think the final question was, would the patient be able to take oral antibiotics? Yes, sometimes patients are prescribed oral antibiotics. In my experience, though, typically drops, because they're topical, they're directed to the ear, they're a bit more effective. But yeah, no, sometimes people can. Sometimes some patients can't have certain drops if they've got a perforation, for example, or they've got some sort of allergy to one of the active ingredients, and they take oral antibiotics. Amoxicillin is quite a common one here, and that can also work. It just depends on the severity of the infection. So that's also possible. I think the main questions. There's someone that wanted me to stop making food references. Unfortunately, that's not going to happen. I do apologise. And there was a few comments there. I've just decided any rude comments, or I'm not gonna respond to it anymore. I'm just gonna block the individual. So I think that's just the better. But I think moving forward, what I'll do is when I'm recording a video, I'll go back to the day before, have a quick look at the comments, and any questions that kind of jump out. I will try and answer them in the preceding video. Well, I hope you enjoyed that video, guys. Take care. Speak to you soon. Bye.